Good evening, everyone. I am Dr. Alish Mehta, a third year MCH resident from Science Hospital. Welcome you all on the behalf of IPS for this IPS NextGen lecture series. The idea of which actually came up by floating that many of the key concepts in pediatric surgery are not well understood, specifically the radiological part. So, to consider this shortfall, we have come up with this NextGen lecture series. We thank our Secretary, Dr. Vikesh Agarwal, sir, for this opportunity. We are going to start the session with the very first difficult but interesting and yet important topic, that is renal scans. This topic will be delivered by Dr. Anand Aladi sir. He's a professor of pediatric surgery at Bangalore Medical College and Research Institute. He has a keen interest in translation research as well as urology. I would like to call upon Dr. Vikesh Agarwal sir to please give two words before starting the session.
I think it's a commendable initiative by our postgraduates, and I'm very happy that youngsters are coming forward. Not only in asking for things to be done by IAPS, but also organizing things themselves. So these two guys, I congratulate for this initiative. And we welcome our guest speaker, Dr. Anand Ladi. Over to you.
Thank you, sir. Before starting the session, I would request all the participants to please stay mute, and whatever queries you have to please post in the comment section, which will be addressed at the end of the session. Over to you, Anand, sir. Thank you.
Thank you. Good evening to all of you. So, starting with the first session of the NextGen series, I'll be trying to cover some aspects of nuclear medicine with respect to pediatric urology. Nuclear medicine is a very large a book by itself. So, we'll try to just today focus on the relevance of nuclear medicine in urology. So, the basic principle of nuclear medicine, whether it is in urology, hepatobiliary, CNS, wherever it is used, consists of using a radiopharmaceutical. Basically, the radiopharmaceutical is a mixture of two molecules, one which is radioactive and the other which is a specific pharmaceutical agent targeting the organ of interest. So if we are using, for example, in kidney, we look at in isotope renogram, a DTPA or a MAC3 or a ethacistine, which is tagged to a radioactive isotope, usually technetium. Whether it is, when it is used in hepatobiliary scintigraphy, we look at mebrofenin. So it goes on. So the radioactivity generally emitted by an excited nucleus as it comes back down to the state of inactivity is usually alpha, beta, gamma rays. But what we use in nuclear medicine is the gamma rays. And the radioisotope with radiopharmaceutical, which is injected, is then followed through in a particular sequence, depending on what is the organ we are studying at various intervals of time, which gives us functional information most of the time. But if applied appropriately, we do get to some extent anatomical information also. I think there is a lot of background talk going on. Okay. So coming to application of nuclear medicine in urology, there are three major types of scans which are done in nephrourology. The ones which we commonly use and most of the focus will be on that is the dynamic diuretic renal scintigraphy, shortly what is called as EC or DTP renogram. Then the second part which is used is renal cortical scintigraphy, or what shortly we call it as DMSA scan, and sometimes radionuclide cystography as a replacement for the micturating cystourethography. The radiopharmaceutical, as I already said, the radioisotope which is used in most of the radioscintigraphy are technetium-99. Coming to the pharmaceutical agent which is used in dynamic scintigraphy, either we have a choice of a glomerular agent, which is DTPA, diethylene triamine pentacetic acid, or a tubular excreted agent, that is methyl dicysteine and acetylthiogisane. We will look at advantages and disadvantages of each of them as we go down further. DMSA or dimercaptosuccinic acid is what is used for cortical static scintigraphy, generally used for looking at anatomical variations and for effect of reflux causing scars on the kidneys. Just before we continue with the discussion on the principle or the techniques of scintigraphy in dynamic scintigraphy, a word about MAC3 or EC, which are tubular agent, versus DTPA, which is a glomerular agent. Earlier, when dynamic scintigraphy came into vogue, DTPA was the agent which was routinely used because it used to be filtered by glomerular filtration, most of it, and follow the standard principle of inulin clearance and GFR. But over a period of time, it was realized that there are a lot of problems with DTPA, and the the renal extraction is very less. So especially in small infants where the glomerular filtration is low, or in children with renal failure, the background activity takes over significantly, and the DTPA renogram gets affected and does not give us a correct picture. So then tubular agents came into picture, initially MAC3 and subsequently ethyl cystine. If you look at most of the textbooks or articles coming from the West, it's always MAC3 which is referred to, basically because ethyl dicystine is not available in the West, and it's usually in the Indian subcontinents and eastern countries where it is routinely used. In fact, if you compare MAC3 and ethyl cysteine, ethyl dicystine has much better extraction efficiency compared to MAC3. If you look at this graph, almost 70% of it is extracted and secreted out by tubular excretion, whereas MAC3 is only 50 to 60. Of course, that is definitely much better compared to DTPA, but still, in situations where you have high situations where you have renal failure, this does contribute to a significant amount of background activity. And ethyl cysteine is excreted only by tubular secretion, whereas MAC3 has a parallel excretion in the hepatobiliary system. So when there is renal failure, there is a lot of isotope which is then excreted out through the liver as an alternative pathway, adding on to the background activity and thus interfering with the interpretation of the scan. So generally, when we now continue talking about dynamic scintigraphy, we will be talking mainly about ethyl dicystine. So coming to the indication of dynamic diuretic renal scintigraphy, all of us know the commonest reason why we use this is for differentiating between obstruction requiring surgery versus non-obstructive hydronephrosis. Most of them picked up antenatally nowadays. Of course, sometimes we do get children who are missed or present late in life due to presenting as intermittent pain like Dietl's crisis, or very rarely presenting with urinary tract infections. The second group of problems where we need to use this to differentiate between obstruction and non-obstruction are the megaureters. Megaureters which have been proven not to be refluxing on MCU already done, or which have an ambiguous picture on the MCU, which may sort of push this group of hydroureters and megaureters into obstructing refluxing megaureters. Sometimes, to complement the other investigation, we do use it in duplex system, ectopic systems, to especially in duplex where there's a suspicion of an obstruction is one of the moieties as against the other moiety. And of course, post-operatively after a pyeloplasty or a reimplantation for megaureter, obstructing megaureter, we do use it to compare to see what is the status of the surgery with respect to improvement in drainage and function. So coming down to the technicalities about how to do the scan, what are the parameters we need to look at when the scan has been done, how to interpret the scan. We start off with the indication we have already talked about. So you have a child where we need to look at doing a renogram or a diuretic scintigraphy. The first most important thing is to make sure that the child is hydrated well. Most of the child, the infants, the mother continues to feed till the last moment, and the advantage of that is a well-fed child is usually cooperative and tends to sleep through the scan, as against a child who is hungry and irritable. The other requirement is to have an empty bladder. We will look at some examples about how bladder fullness influences the interpretation and the graphs of the drainage, the renogram. Renal versus tubular versus glomerular agent I've already discussed, so we will stick to only tubular agents, that is ethyl dicysteine, what is routinely used in Indian subcontinent. Some do use MAC3, but like I said, if you have a choice between MAC3 and EC, I would still recommend to use EC against MAC3, though MAC3 is, and MAC3 being more expensive, is still used in many of the corporate nuclear medicine labs. The third thing is, since as the name suggests, it is a dynamic diuretic renal scintigraphy. So the word diuresis, diuretic, brings in the use of furosemide, which is routinely used. There are different protocols about how to use it, advantages, disadvantages of each. We'll come to that later. So using a tubular agent in a well-hydrated baby, preferably with a bladder empty and with diuretic being used, is how the test goes about. Once the child has been injected with the radiopharmaceutical, and of course the furosemide, which can be given, most of the time we use it, what we call the F0 protocol, where the radiopharmaceutical and the furosemide are given at the same time, and this is followed by a series of acquisition of different frames at different speeds and different intervals. So there are, if you look at a graph which we'll be seeing shortly, the whole renogram has three major components. The first component is acquisition of the activity over both the kidneys and putting it on the time activity curve for the first 1 minute at different, either at 2 seconds per frame or 1 second per frame. It varies from lab to lab. The child is usually kept supine and the capturing is posteriorly. Nowadays, with dual cameras being used, you can use anterior or posterior, selecting what you want instead of having actually to put the child in different positions. Posterior supine frames are what is routinely used. Anterior are used in certain specific situations, especially when you are looking at ectopic kidneys or in horseshoe kidneys, because the acquisition needs to be, especially when you're using it to calculate differential function. So in these specific situations, anterior frames are acquired as against the routine posterior frames which are used. And in some specific situations, for example, when you have a megaureter and there's a significant amount of tortuosity of the ureter and is hold up in the pelvis also, to sort of unfold the pelvis to see whether it's actually an overlap with a kink in the pelvic junction, what is due to a secondary PUJ obstruction, or it is just a overlapping dilated ureter with the normal pelvic junction. So in these sort of situation, you can add on an anterior view along with the posterior view, which may sometimes open up the they open up the full 360-degree information and give us proper information. So once the acquisition starts, the first 1 minute is the perfusion frame, and this is followed by, for the next 20 to 30 minutes, what is called a drainage phase. This is acquired at again 1 or 2 frames, one frame every 1 or 2 minutes up to 20 minutes. The third and the most important picture, this is what I'll be reinforcing again and again, is the delayed picture, which should be taken after the baby or child has voided. So it's a post-void delayed picture, and after ambulation or gravity assisted drainage, because many times you have a redundant pelvis, and unless the child is made to sit up or held vertically or move around, depending on the age. If it's an infant, mother takes a child, holds it vertically and moves around for some time. If it's an older child who can void and command, he walks around for some time and then voids. A delayed post-ambulated or gravity-assisted drainage post-void image is what is required for us to look at and say whether there is obstruction or not. There are a lot of parameters which are used for quantification of all these things. We will talk about that shortly. The major factor which then is used to give us the final report is mostly done by the nuclear medicine physicist or the technician. They need to be aware. You should have a good rapport with the nuclear medicine physicist, preferably go sit with them, understand how they do it, because especially when there is significant difference in the differential function, the drawing of backgrounds to subtract the background activity, number one, and to calculate their activity from the kidneys, number two, are very important. And I'll show you some examples where just changing the background, drawing the background, can completely change the differential function or the pattern of the curve. And then, of course, calculating the differential function. And once we have the differential function and the post-ambulatory post-void picture, these two major parameters help us decide whether there is a obstruction requiring intervention or something which we need to be looked at. Since the parameters are significantly affected by a lot of artifacts, most of the times we end up actually eyeballing the scan and then coming to a conclusion. And there are a few situations where unequivocally we can say there is an obstruction with compromised function and go ahead with surgery. Many times when there is a doubt, we have to rely on other investigations, ultrasound, MR urography sometimes, or relook at doing an isotope renograph after a particular period of interval to see what is the interval change, and then decide whether there is worsening requiring intervention, there is static requiring further observation, or there is improvement saying that they can now be confidently put off and followed up at a slower rate. There are always this question about radiation. Radiation from a nuclear medicine scan is very low. If you look at the normal environmental radiation, what all of us are exposed to, it is less than 70% of what in a year a person would be exposed to by natural background environmental radiation, or less than 5% of a permissible annual radiation exposure to a healthcare worker. But still, younger children, organs being smaller, the radiation being having collateral effect, they are definitely more susceptible to radiation compared to adults. So this should always be kept in mind. And when we do these scans, when we repeat the scans, all these factors should be considered. Sedation sometimes are required when the child is very mobile, ambulant, but however, sedation does interfere with renal drainage and can again interfere with the interpretation of the scan. So coming to the only one situation where DTPA is actually used is post-transplant evaluation, because in most of these, we are not actually looking at obstruction and other things. We're just looking at how the transplanted kidney is working. And for GFR estimation, now there is a important point I want to stress here. GFR, most of your nuclear medicine centers will give you a GFR based on the EC scan, based on a DTPA scan. But the GFR which is calculated is a machine value which is calculated using the Gates technique, which is only appropriate in adult patient. Children with variable surface area and variable depth of the surface tissue, is this GFR estimation is totally erroneous. And the only way you can actually get a GFR is by using DTPA and then taking multiple blood samples and then looking at the washout rate and calculating it, which is not logistically feasible, trying to poke a child repeatedly and get samples to see the washout. So generally the GFR is not something which we would rely on or even look at in the report. So with this background, let us look at a few pictures to get a better understanding. So this is a typical scan, which you'd see. I will also talk about some differences which different labs will be showing if you look at textbook pictures versus the pictures which I'm putting up. Now, like I said, the first series of pictures are acquired, like it may be 2 seconds per frame, 1 second per frame, but whatever it is, this is for the first 1 minute. And this is what is called a perfusion or images, perfusion frames. This is whatever is acquired here are always put on a time activity curve. These curves are called time activity, with the x-axis showing the time and the y-axis showing the radioactivity. The same thing is also obtained for the second series of images, which are looking basically at the drainage. And this again is put on a time activity curve here. The third important factor which I was talking about is they do have an early static image, but most important single image if I want to look at will be the post-void, delayed, post-ambulatory or gravity assisted film. So this is something which is going to tell us how intense it is compared to what we started off with, persistence of the isotope in the kidney without any change, or in fact, it may be darker compared to what it was earlier, to say that unequivocally there is an obstruction in this patient. Now, when you look at this, why I said eyeballing, there are a lot of other factors. Now, for example, normally the aortic activity is highest and should come down slowly. There are sometimes artifacts, and when you look at the kidney activity from the beginning, this seems to be in a parallel line. Why, if you look at any of the textbook images, whether it's in Campbell or one of the nuclear medicine books, you will see that these are all very smooth curves coming down, and these curves are something which are starting from zero going up. The reason why this happens is many of these children, the nuclear medicine centers who are doing pediatric nuclear scans, they try to use scalpel sets or a IV needle, directly inject the furosemide and the isotope, which is diluted. So there is a dilution component in that. So you don't start off with a peak. Whereas the ideal way, which is injected in, and the pictures which you would see in a textbook would be those which are injected, hardly 0.2 ml of volume will be there, which is the radioactivity or the dose of the radiopharmaceutical which is injected, and that starts off with the immediate spike and the aorta and gradually get washed out, that is taken up by the kidneys. So there is a lot of discussion which goes on about whether the background has been drawn properly or not, and how to say whether the background subtraction is appropriate, overcorrected, undercorrected, etc. We won't go too much into technicalities. For example, when you look at this, it's very difficult to just look at the picture as it normal magnification. So what I would suggest to all of you is that in the initial stages, take a picture, put it on a laptop, and then just try to keep zooming and looking at the picture. So if you look at this picture, it becomes a little more clearer. You can see that right from the beginning, 2 second frame, 3 seconds, 6 seconds, every time you see there's already good amount of activity in the left kidney, whereas the right kidney is hardly showing any activity. Coming down almost at the 7th or 8th film, there is some peripheral activity which is starting to come. And by the end of the perfusion images, almost the excretion has started into the collecting system on the left kidney, where the right is still tending to fill up. So in this sort of a picture, it's very obvious that this child has a kidney which is very poorly perfused compared to the normal kidney in a unilateral picture. And as we come down further, you can see the left kidney is becoming fainter and fainter, and by the end of 30 minutes or so, it is completely emptied out, whereas the right kidney is continuing to fill up, and the intensity is becoming more. If you just look at it far off, it looks like the whole thing is dark, but when you look at it closer, the central darkness is gradually increasing until the end of that series of recording. And finally, when you come even in the early static, you can see that the central pelvic activity is quite less. So the cortical transit is continuing, the nephrogram phase is continuing, or whatever is the equivalent to the nephrogram phase, the perfusion phase still continuing. And in the delayed picture, this is excreted out more from the parenchyma into the calyceal system, and the intensity in the calyceal system has gone up. Now coming to the differential function, I'll talk to you in the further slides, but just for completion here, the differential function is calculated by the machine, which software is usually depending on the protocol used. If you use DTPA, it measures it from 2 to 3 minutes. If you use Mach 3 or EC, it records it from 1.5 to 2.5 minutes. So generally the parallel lines, if the reports which are given to you, is the period in between two of which the differential function is calculated. It's basically integrated from here to here and then given. Now, if you look at this, there will be a difference if you calculate a different function here versus here and versus here. So just come to that. Now, why I said again, eyeball is you don't need all this mechanical calculation. Just looking at it, anywhere you calculate, whether you calculate here, it is very obvious that this function is almost 3 times or so of this. So if you want to get a numerical value, you just draw a line, see where it meets, draw a line where it meets, then A and B, A by A plus B, B by A plus B will give you the differential function. More or less, it will match what they are given. So in this is a typical renogram where there is not much of ambiguity. You don't have to worry. It is definitely a poor functioning kidney. It's an obstructive system. This function you can keep for reference for further comparison post-operatively. Sometimes when you see the picture, you may get a lot of these artifacts. Now, these artifacts are caused by 2 reasons. One is the movement artifact, and because of that, it is always good to look at the cine if you have an access to the lab, or even ask the nuclear medicine guy to send you a cine recording on WhatsApp along with the report. So if the child keeps going in and out of the region of interest because it's moving, so you keep getting high and low peaks on that. The other reason why they can have this sort of picture is if the bladder is full and the child also has associated reflux. So as it is emptying, then suddenly there will be a period peak going up again because of reflux. So that you would generally know when you look at the films which are recorded, that there's some activity there corresponding to that particular point of time. For example, in this, if you look at, you would see if there is a biphasic point at say minute 5, then you go at minute 5 and see, you would have seen the ureter having activity. So that will differentiate between movement artifact and a reflux. Now this is an example of how a cine would look. I will also show a similar picture later and the importance. So you see that the washout has already taken place here, whereas this is still continuing to accumulate. And this gives you a rough idea about what sort of problem you would be facing with in this patient. But as you see, as we come to a later phase, even this is getting washed out. Now, there are certain things which you want to know. One, of course, is the hydration. The one quick way of knowing whether it's a well-hydrated child or not is to look at what point the bladder is being visualized. If the bladder in unilateral obstruction is visualized by the 3rd or 4th minute, that means the hydration is good. Of course, you can also look at the appearance of the isotope in the pelvic calyceal system, and that generally happens but around the 2nd minute or so. One of these two should be able to tell you the hydration is good. And these slope curves, if it's a rapid upgoing slope and the downcoming slope like a bell shape with a slight staggering, it generally means the hydration is good and excretion is good. On the other hand, if it's a very slow upgoing slope and a very slowly downcoming slope, then we need to look at this and make sure it is not because of poor hydration or a full bladder. So you can see that in this picture, both the activity curves are rapidly going up, basically telling us the child is well hydrated. Now, if you see the bladder being full and if the bladder is not empty, that is the reason we always look at delayed picture. Earlier, the well-tempered renogram protocol by the Society of Nuclear Medicine insisted that every child has to be catheterized, but nowadays we don't catheterize mandatorily. It is, of course, some people still do follow it, but it is not necessary to have a catheter in situ because we'll be anyway having a post-void frame which will be looking at. In specific situation, when you're looking at VUG obstruction, megaureters, or duplex system, or some other bladder associated pathology, then in those situations, bladder drainage is required. But this is an example of how the curve would look if the bladder is full. You can see that it's a slow going up. Neither of them are obstructed. It's almost equally functioning kidney, but the curves are going up very slowly and also coming down those very slowly, though it is emptying at the end. Whereas in a well-hydrated child, you can see it goes up and comes down rapidly. So this is one. And if you look at this, you can see that most of the time the bladder is empty and what ends up in between is also getting emptied out. So bladder drainage can interfere. Differential function, I already told you, depending on the software which is used, it's calculated between 1st and 2nd minute or 2 to 3 minutes. Now, when calculating differential function, certain things have to be kept in mind. So this is an example of what I told you. Now, this machine has calculated, this is the first patient which we saw. The right differential function is 20 and the left is 80 almost. So this is very clearly seen in between these two. If you take the midpoint and draw this, it is at 800 and this is at 200. Now, suppose there is no way you will get a perfect differential function because the differential function is ideally supposed to be calculated at a time when the entire cortex is filled up and drainage into the pelvic calyceal system is not started. Now, if that is so, and one is draining slower than the other, at no point of time you will get both the kidneys having the cortex fully filled up with isotope. So suppose we decide to calculate at the time when the normal kidney is having the full peak activity. In this case, the function changes from 1000 kilo counts in the normal and 10 in the abnormal. So what was 80-20 become 90-10. On the other hand, if we say that we will calculate at the time when the affected kidney has got maximum activity, by that time the activity from the other kidney is already washed out, and what was 20-80 or 10-90 here becomes 40-10. So there is a lot of ambiguity and fallacies in directly depending on the differential function. In addition to that, if you have a normal kidney, which is compensated well and rapidly drains out. You can see in this kidney, it is already started to drain out. Now, this kidney with this function, if you look at it, is might have been actually a overestimation. So this is one of the reasons where you get a hyperfunction. When the normal kidney has washed out so rapidly before the differential function is calculated, it gives a false high activity in the affected kidney. And in addition to that, when the affected kidney is very grossly hydronephrotic, the background activity continues to add on to the area of the pelvis and the kidney, and that also adds on to a hyperestimation. So there are most of the hyperestimated function are artifacts. So generally, just then depending on the function, what you would need to look at is the perfusion to see that the kidney is affected significantly, and the post delayed picture, which I was talking about, to say there is an obstruction. And in the series of pictures, you would be actually able to show that the continuing accumulation still is happening in the affected kidney. So that kidney is definitely compromised. Now, region of interest is what is drawn by the technician or the physicist over the kidney or the whole kidney or the parenchyma to calculate the differential function. Now, if you put especially when you're doing a very grossly hydronephrotic kidney, putting the region of interest on the entire kidney completely sometimes changes the differential function. So this is an example of a patient where the region of interest first has been put only on the parenchyma and not on the pelvic calyceal system, and the differential function of that kidney is 41. You can see that this is an obstructive kidney. Even in the delayed picture, it is significantly being held up. Now, the same picture on the computer, when we changed the region of interest, this is the same patient. We just changed the region of interest. You see that the function increased because it is also taken the background activity from behind the empty pelvis, taken some of the activity in the pelvis and added it on. So what was 42, 43 became 52. And this is again already an obstructed kidney showing significant obstruction. And if you see all these frames, there is definitely poor perfusion. So in this child, if the ultrasound had shown a hydronephrosis and this was the isotope scan, without looking at any of this, by just looking at this and this, I would say that this is a child who has had compromise already in the perfusion, significantly requiring intervention, obstructive pattern even in the delayed picture with significant holdup, and say that this child would require a intervention without actually looking at the differential function. Now, background subtraction is something which is very important. That is the area of ROI put on different ways. So some labs would put it only on the infralateral aspect of the kidney, both kidneys, and some would put it around the kidneys, and some put it one above and one below. So the one above will subtract the vascular background activity, and one below will subtract the tissue background activity. Now, this is an example of a child where the background activity has been put around the kidney. The background subtraction RO has been put around the kidney. The left kidney shows a differential function of 61 and the right is 35. When the same child, when the background activity was changed to infralateral aspect, the differential function also changes. Now, this is a fairly well empty kidney, so it didn't make a major difference. But in an obstructed kidney, this would have significantly changed the differential function. So though most of the books would say that this is what they use, in children, especially with spleen and liver being there, it is always preferable to use the background subtraction curve around the kidney. But this also has to be very carefully placed. Putting it a little too laterally will put it on an area or almost subcutaneous tissue, because children do not have so much of muscle and fat, and subtract very little and again give a falsely high differential function. So the most important parameter which I said we would be looking at to see whether there's an obstruction or not is the delayed post-ambulation or gravity assisted post-void image. This is a typical picture which I showed you. And if you see the immediate static, there are significant holdup in this child, but subsequently after 2 hours, it has completely drained out. So this would have definitely ruled out obstruction. And this, you can see the activity is continuing to increase even after delay and post-void. And this is a difficultly obstructed pattern. Now, there have been attempts to quantify this. So many values have been used. One of the things which is talked about but not much used in many labs, 1 or 2 labs do use it in India, is to give it a numerical value and what is called as a normalized residual activity index, or the NORA index, where the residual kidney counts over 1 minute period is recorded at a particular time, usually at the 60th minute. And this is divided by the kidney count at the second minute, that is at the parenchymal phase, where maximum concentration of the isotope is supposed to have been occurred in the kidney. So that basically tells us what percentage is still remaining, and anything above 1 or 1.5 is considered as abnormal. So in this child, if you look at it, the left kidney, the index is 3.38. You can, and the right is 0.05. You actually don't need this number. Like I said, if you look at this, this is a good image at the second minute, where entire activities come from the parenchyma into the pelvic calyceal system. At the 90th minute, there's not even a speck of activity. So this is the normal kidney. Whereas here, you can see at the second image, it's still poor perfusion, just some amount of darkening occurring along the cortex, nothing coming to the pelvic calyceal system. And in the delayed picture, everything is still held up here. So you don't really need this quantification. Yes, academic interest, you want to do it, you want to build up a series and look at different parameters, you can do it if you want to do a thesis. This is an example of another child where the activity has disappeared completely and index, both of them are less than 1. Again, you don't need this calculation. You can just look at it and say, but this is something I just put up because some of the European and Western centers, if you look at the report, they do give this as a parameter. But this is the same thing. Qualitatively, what we check, they has been quantified, semi-quantified. Just a couple of examples where we had done a study in our department. Every patient underwent DTPA and 48 hours later EC scan. You can see how in the same patient, the activity of the curve, the pattern of curve has changed. So this is a child where it gave a picture as if the right kidney was an obstructive pattern going upward, but with EC, it was a classical, normal, downgoing slope. Similarly, another example where the DTPA was slowly coming down in the normal and trying to give an appearance of a upgoing curve on the other abnormally dilated side, but on the EC, both of them showed a downward phase, ruling out obstruction. The same thing when you compare the delayed pictures, post-void pictures in DTPA, you could see in this, you would have thought at 4 hours, persistent hold up, we would have given a report as an obstructive hydronephrosis. But when the EC was done, we could see that the whole thing was cleared out. Similarly, another example where it was thought to be obstructive, but in the delayed can, it was completely ruled out by clearance. So definitely tubular agents are preferred, and a lot of other artifacts are taken away compared to the glomerular agents. Even the differential function changes. So this is an example where the DTPA was done, and if you look at it, 47% on the DTPA changed to 64, 52 became 36, whereas 57 became 74 and 42 became 25. So this was a more likely and true picture compared to this. So differential function can change, the pattern of the study can change, and this is just what were the findings in thing. In 14 patients, when we did EC scan out of 32 patients, we were able to rule out obstruction with the DTPA otherwise reported, and if you had gone only by DTPA, would have ended up operating on these people. Sometimes you get intermittent hydronephrosis, and when you do a renogram initially, you would see that there is no obstruction and a normal function. So we need to do in these children the repeat scan, or we need to, especially this is common in older children, when they have pain, and pain being the presentation and ultrasound shows hydronephrosis, it is always good to do the isotope scan exactly during the episode of pain. So you may have, this is actually a patient where it was repeated after 3 days when the symptom was there, and this was done at a time when he had presented to us with 4 days history, 4 days back having pain, but at the time of present, and ultrasound being done outside showing hydronephrosis, but when he presented on the day he presented to us, he did not have symptoms, but the isotope scan was done and it showed a common completely normal draining pattern with preserved function. But when it had a recurrent episode, at the time of episode, it showed a typical obstructive pattern with a drop in function. Of course, sometimes there is this discussion about diatal crisis in older children having actually an anomalous vessel, and that would be the cause of obstruction. We won't go into that discussion, but just an example of a child where we decided to do a CT angiogram and showed that there was an anomalous vessel. But many of these, it's not just a vessel, there is an always associated intrinsic obstruction. So an example of why we need additional investigations to be looked at. If this child had been just sent with this film to us without looking at the ultrasound, initial frames, yes, there is poor perfusion on the left side. So you would have said there is a left poorly perfused kidney, probably obstruction. And when you here, it's very obvious. But if you look at these pictures, it just looks like this is a smaller kidney continuing to get more and more accumulating dye, and in the delayed picture, persistently there. But if you look at it more carefully, and you can have some subtle findings that in the perfusion phase itself, this lower half is filling up, and as we come to the end, the intensity is gradually increasing. And when the drainage phase is being looked at, you can see it is like a pear-shaped thing, as if there is some decreased activity, what you would have seen in a DMSA scan ideally. But as you go, this becomes oval. So that means there is activity coming up slowly in the upper part. And as you go further, the lower part is becoming fainter and upper part is continuing to hold up. So this at the end of 20 minutes is actually showing only the, as if an inverted picture of this. Here you could see lower half intense activity, nothing here. Here upper half intense activity, nothing here. So this definitely raises up suspicion of a duplex system. And initially this was reported by a junior technician as just an obstructive system. But when we went back and we showed the ultrasound picture, you could see a typical duplex moiety here. And in the delayed picture also, you could see the upper moiety was the one which was slowly excreting. So obviously perfusion is lower in the upper compared to lower. The lower moiety has completely cleared off and upper moiety continues to hold up, typically an upper moiety obstruction. And in the delayed picture, when the bladder post-void, some amount of urine has refluxed up. It's typically what you would see in a duplex, lower refluxing moiety and an upper moiety with obstruction. So additional investigation relates is very important, and looking at the pictures very closely when there is something out of normal or unexpected is very important. So this is in a picture. Now when you come to looking at hydroureteronephrosis, so then we did an MCU because this child had presented to us with a hydroureteronephrosis. When we did the MCU, you could see here that this is typically what you see in a obstructing reflexing megaureter. One, there is a typical narrow zone and then dilatation. Normally a reflex, straightforward reflex will be dilated right from the beginning. You won't get this sort of a narrow zone and transition. This is what sometimes is referred to as Hirschsprungs of the ureter. You have a typical, what you would see in a contrast enema for Hirschsprungs, a narrow contracted zone and a dilated proximal zone. And if you're doing the MCU, which ideally we would do under fluoroscopy, the moment it starts reflexing, this whole contrast starts getting diluted. That means there is already significant amount of urine lying in this, and it's not drained out into the bladder when you put the catheter. And you could see the difference in intensity of the color in the bladder and in the ureter, which has reflux. So this is what, there are 4 criteria described in an MCU to say it is an obstructing refluxing megaureter. So when we had this picture, we decided to do this with the catheter in situ. And again, in this picture, you could see that in the perfusion phase, there is no doubt that this left kidney is poorly functioning compared to the right, and continues to excrete gradually till the end into the pelvic calyces system. Ureter in the right is persistently seen in all the frames, dilated and holding up, suggesting of some hold up of isotope in the ureter, probably obstructed because the catheter is also there. The reflux contribution to the ureter is already ruled out because the bladder is empty. So this is probably an obstructive megaureter. And when you look at the images, the static, early static, delay static, and another this thing about knowing the techniques is that many times the Lasix, though it is not described in book, our nuclear medicine, my colleague Dr. Murli, who generally does all our nuclear medicine scan, he uses a protocol especially for these sort of picture and in patients post-op after pyeloplasty, when you have the reservoir effect and it is still showing a sort of slow drainage, and some doubt always arises whether it's a recurrent PUG obstruction or it's a reservoir effect. It is F0 and again a repeat Lasix growth at 60 minutes, which then drives it out completely and rules out recurrent PUG obstruction as against a reservoir effect. The same thing was also done in this patient when there is persistent holdup. So you could see the right kidney is already drained out from the pelvic caly system, but still isotope holding on here. In the delayed, still some amount of isotope is there, but it is gone. So a repeat Lasix dose was given, and post that you could see the right had completely cleared up. On the other hand, the left, as you saw from the beginning, is poorly functioning, poorly excreting, gradually accumulating, and even after that, this is tending to hold up, showing a typical definite VUJ obstruction as compared to the megaureter on the left, which is only a refluxing megaureter. Now, this is an example where I said you sometimes anterior views use. Now, when you look at this picture, sometimes it might be also on the MCU because of the dilated tortuosity, may look like a secondary PUJ obstruction, like a narrowing. But when you have an anterior picture along with that, you see this whole thing is well dilated and it unfolds, thus telling us that this is very unlikely to be a secondary PUJ, but it's just a dilated system which is holding due to the back pressure. And MRU would probably confirm this and definitely give a further clarification. Another example of a VUJ obstruction. Now, many times we have reflux on the MCU. You don't know whether it's a secondary VUJ obstruction or a PUJ obstruction, a secondary PUJ obstruction or a PUJ, PUJ obstruction with an associated reflux. Generally, if it's a straight tube going up with not much of tortuosity, it is more likely to be an associated reflux than a PUJ obstruction with due to secondary tortuosity. On the other hand, if the whole thing is tortuous, persistently holding up, in spite of catheter drainage is holding up, then it's probably going to be a secondary PUJ obstruction. So this is again one of the thing about hyperfunction and associated with an obstructive pattern. I have gone through that. I just show a cine to reinforce how that. See, so this picture, if you see, the left kidney is already filled up, pelvis is filled up and already excreting, whereas the right is just started to fill up. Now, most of the time, the computer will calculate a differential function somewhere here. Now you can see that by that time, most of the activity has come and disappeared from this, whereas it is still accumulating here. And that is the reason why it would give you a false higher function in this. In addition to that, if the ROA had included a pelvis, it would include a lot of background activity here. And third, the background curve, which is put, the ROA for background subtraction, which is put, if not appropriate place, all these three would contribute to give a very high result. And most of them, almost exclusively, all the hyperfunctions are artifacts and not a true hyperfunction. And this has to be kept in mind, especially when counseling the parent, because at the end of pyeloplasty, when you do a repeat scan later, this will change and it will actually show a drop in function. So when you talk to the parents, always show them the drainage curve and the perfusion and tell them clearly that a hyperfunction is an artifact and it may not actually improve. It may even worsen. So this you are covered. Then VUJ obstruction, where you keep the in the VUJ, when you're looking at VUJ obstruction, in addition to the region of interest, when you put on the pelvis, you also put a region of interest on the ureter. So this is a VUJ region of interest. Initially, you could see the pelvis emptying down and come, and then at the area of the lower end of the ureter, the activity keeps going up and up and up slowly. That means the isotope has come down to the kidney and peristalsis comes, it doesn't go down, it tends to go up and again come down because there is significant redundancy here. So it keeps going with every peristaltic wave up and down and giving us a picture of a seesaw pattern on the time activity curve. So these are again some examples of megaureter. And this is again a child who has dilated tortuous ureter, persistent poor function. And if you look at that from the beginning, the perfusion is poor. Generally, if you have this sort of a picture, there is significant amount of PUJ component because a megaureter tends to dissipate the pressure in the tortuosity and does not cause a drop in function significantly compared to a PUJ obstruction. So these are probably children who have had a PUJ obstruction with reflux or a double obstruction, very rarely a VUJ with a PUJ obstruction. So these things will have to be looked at, and when there is a low function, significant perfusion being low, and a pattern like this, we would always concentrate on tackling the PUJ first and then looking at what, if anything is required or what is to be done to the VUJ. So this is an example when the ultrasound was reported, the very long redundant pelvis was reported as a mega ureter and mega hydronephrosis. And when we looked at the EC scan, it was showing only a PUG obstruction. So when we looked back and then did an MRI urography, it was very obvious that it was only a pelvis which has been stretched so low, and the ultrasound cut at this point thought it to be a ureter and reported as a hydroureter. But this was very clear that it was a PUG obstruction. So basically, there are a lot of pictures, but I don't think we have time to keep going through other. What I would recommend as students and young consultants is that when you get an isotope scan, do not look at the report. Take the isotope scan, look at all these parameters. First, do a quality assessment. See whether the hydration is okay. See the sharpness of the curve or the bluntness of the curve. Look at movement artifact. Movement artifact, looking at the curve, will make you suspect. If possible, get a cine. And then look at the regions of interest which has been drawn for background elimination and for differential function. Once you have done the quality assessment check, then start interpreting the scan. First, look at the perfusion images. Make a tabular column of your own. Keep putting quality check 1, 2, 3, 4, yes, no. Parameters, number 1, perfusion, good, compromised. Then differential function, like I said, calculate yourself at a midpoint and put what is the differential function. Number 3, look at the delayed post-void, post-ambulatory film, see what is the intensity compared to the immediate post-completion of the dynamics portion, record obstruction, non-obstruction. Once you have made your own report, go back and see what the official report has been given. When there is no concurrence or there is some ambiguity between the two, call that person, talk to him, understand. In few situations or most of the unilateral situations, there is no ambiguity. You have a PUG obstruction with a compromised function very clearly. So you can go ahead with the procedure for relieving the obstruction. But in bilateral situations, in ambiguous situations, in hydrouretronephrosis with double sort of problems, always repeat the scan with the same technique. Use whatever you had used earlier with the same thing and then compare and see whether there is any change for the better or worse before you commit to a particular modality of treatment. So if you have another 5 minutes, I'll just rush through DMSA and this thing, or I can stop.
No, sir, please continue, sir. Please continue.
Can you hear me?
Yes, sir. Yes, sir. We can hear you, sir. Please continue, sir.
Okay, then let me go back to that quickly. Sorry. So DMSA, we generally know there are two gross indications. One is to look at the consequences of UTIs following reflux. The second is to look at anatomical variations in ectopic kidneys, duplex moiety, cross-diffused ectopias, horseshoe kidneys, and all those things. So the common application being in urinary tract infection associated reflux. There has always been this debate about which to do first, whether the MCU or the DMSA. So there are certain things which literature and our experience have said that any urinary tract infection associated with reflux, when the first infection causes some damage to the kidney, when you do a DMSA, it may be very early, it may be pyelonephritis. When you do it very late, it may be showing a scar. But when the first urinary tract infection has caused changes picked up by the DMSA in the kidney, these are the kidney which are prone to repeated damage with every urinary tract infection. On the other hand, if the first DMSA following a urinary tract infection is normal, it is extremely unlikely that that person will have any renal damage irrespective of any amount of UTIs he gets. So these are the safe refluxes who can be followed up more conservatively, whereas the ones which urinary tract DMSA showing changes after the first UTI are the more dangerous refluxes. We need to be followed up more closely, and your threshold for intervention being low in this patient, especially if it is bilateral. So the first earlier negative DMSA is almost always negative. Is 98% of children who have a negative DMSA change after the first UTI will never develop a pyelonephritic change or a scar after subsequent infection, even in the presence of reflex. Second thing, when you're looking at DMSA, remember certain normal image variations. On the left side, because the spleen, there may be a slight indentation which may appear like cortical scar. When it's a grossly hydronephrotic kidney, there may be the pelvic calyceal system which is never filled up, even in the delayed film, giving appearance of photopenia. These are not scars. They will be able to easily differentiate them because of the symmetric way and distribution they are. The recording after the DMSA injection is again a supine. It's a static image taken after 2 to 3 hours after the injection. Usually 3 important views: posterior, left and right posterior oblique views are taken. And to say it's a scar, all the views in the same area should show the changes. Again, in specific situations like horseshoe kidneys, ectopic kidneys, we do take anterior reviews. Now, an example, there is the second discussion which is usually held is about when do you do the DMSA after the UTI and when will you call it a scar? Whether it should be done 6 months after the UTI, whether it should be done 1 year after the UTI. So there is no specific pattern. I'll just compare 3 studies here, which shows that it really doesn't make a difference. So that is the reason that since there is no clear-cut in time frame to differentiate between scar and pyelonephritis on the one hand, and on the second, any change in the first scan itself tells us that we have to be careful. We do not need to be very categoric about when to do it. We can do it after the first UTI once the acute phase has been settled down, and then use that for follow-up for subsequently. So this is an example whereas the first publication of 309 patients, 15% of 61% of patients who had changes after the scar continued to have the changes at 6 months. So what they did, they had a DMSA after the UTI. They picked up all those who had so-called photopenic areas and repeated the scar after 6 months. And they found that only 61% had acute changes, but of the 61, only 15% continued to have. So they said these 15 are scars, the remaining were actually pyelonephritic changes and resolved. So the first recommendation was that do the first DMSA after 6 months, and then you'll be able to tell whether it is scar or not. But later, another study came up where they had 105 patients. They did first scan at acute phase, repeated it after 6 months, repeated it after 1 year, and they found even at 1 year, there continues to be resolution. So those who had changes, 35% of the people had pyelonephritic changes at the first scan at the time of UTI. After 6 months, this 35% became 30. So they said 22% has resolved. So only 13% are done, and these 13% were actually scars. But when these patients were again repeated to a DMSA after 1 year, this 13% became 6%, saying that even at 1 year, there is resolution. So you do the first DMSA at 1 year, then you call it a scar. Then came another study which did it at 3 years. And they say that even up to 3 years, resolution continues. So there is no way absolutely which you can say it is a scar or it is not a scar. So more important for us is knowing that an UTI in this patient is going to cause inflammation in the kidney, and they have to be very well followed up and carefully looked after, as against DMSA which are normal after the UTI. So these are examples. You can see this is a typical patient where one side it's hardly any activity, poor functioning kidney with lot of irregularity, and even in the other side there is a scalloping suggesting a scar. Again, you can see a wedge-shaped defect in this patient. The other kidney is hardly showing any function. The only other kidney showing a function. This is an example. This is a child who had tethered cord, neurogenic bladder, reflux, and came to us very late and had almost a solitary functioning kidney with a scar. So this is again a child which you can see typically what you would see in a duplex system with poorly functioning lower moiety, a horseshoe kidney with some amount of changes due to UTIs. The last part I would like to just go through is the use of the radionuclide cystography, which can be used as an alternate to micturating cystourethrogram when we are treating only vesicoureteral reflux. Yes, the first study is always in MCU because we need anatomical delineation, especially in boys. On other hand, for follow-up, we can use radionuclide cystography. The grading, especially with the present management of reflux, where we are not looking at treating every grades of reflux, but classifying the reflux as low and high grade or non-dilating and dilating reflux, DRCG is suffice to give us that information. High grade, mid and low grade, as you would see in the 5 grades what you would see in MCU. So this can be used for follow-up of patients who have been detected with reflux, for siblings evaluation in patients with positive VUR, and for patients as a screening tool in female children when they have had UTIs and no other ultrasonic changes. So this is something which you could also keep in mind. There are been attempts to actually do a urodynamics sort of thing, or with this they have avoiding, just like you put a time activity curve on the pelviureteric junction and see the rate of disappearance, you put a time activity curve and see the rate of disappearance, and it gives you a radionuclide uroflowmetry. So these are all things which you can play around with your system using quantification of the parameters which are there. I think I'll just stop at that. And this, if you have any questions and you want to discuss that, we can go ahead with that.
Thank you so much, sir. Sir, we've received some questions. I think Alish has posted on the chat. One person wants to know what is the minimum age required to do these renal scans?
So, like I said, since the MAC3 and the tubular agents are not dependent glomerular filtration, the
Yes,
glomerular
sir.
maturation usually takes minimum 4 to 6 weeks.
Yes, sir.
So, if the DTPA was being used, or as it was being used earlier, the recommendation used to be to do the renogram for 1 month to 6 weeks.
Okay, sir.
On the other hand, with EC being available, DC and MAC3 being available, the information is much clearer and almost as you would get at a later age, and can be done even earlier.
Earlier.
But
Okay.
there is also a component of tubular maturity
Yes.
other than glomerular maturity. Tubular maturity occurs earlier than glomerular maturity, but there is still amount of tubular immaturity in the newborn period. So there would be some amount of artifacts even in this. But having said that, if you are using EC as against MAC3, since there is no other mode of excretion and it is only by tubular excretion, you could still get information. But that is not the problem. The issue is tomorrow, if you have a newborn with a unilateral hydronephrosis with a palpable kidney, by doing an EC scan at first week of life, are you going to go and operate him on day 8? If so, fine. But if not, why do you want to subject him to something which may have artifacts, and do it at the time you're going to operate? There
Yes,
are
sir.
certain situations where you have to take urgent decision, a solitary kidney with PUG obstruction, or bilateral gross PUG obstruction with altered renal functions, in which case you need to quickly come to some decision about whether you want to operate, how quickly operate. In these situations, you could still do it in an earlier period at 1 week, 2 weeks of age, and use tubular agent, specifically EC.
Okay, sir. Sir, the second question, I think I'll modify that a little. We've understood that EC scan is clearly much superior to a DTPA when it comes to a diuretic renogram, but is there any indication for which DTPA would be specifically useful?
I have already covered that. The only situation where we do DTPA is post-transplant evaluation.
For the GFR evaluation.
For post-transplant, for just the functioning of the kidney, and for GFR. Now,
Okay.
GFR, for example, if you looked at the older DTPA scan, they used to give us a GFR and give a split GFR. But the split GFR is nothing but total GFR divided as per the split difference,
Yes.
split function.
Yes, sir.
Really never used to give single kidney GFR.
Yes, sir. Yes,
And
sir.
the only other way we would need to do a GFR is to do multiple sample. We actually did this study in AIMS when Dr. Murali was there at that time also. And at that time, they used to say you take 5 samples every half an hour, just like you would do a glucose tolerance test for diabetes.
Okay.
So you
Okay,
take
sir.
5 blood samples, first take the syringe count, post-injection sample, for every half an hour, you keep taking sample, then see the washout. This is the same principle which is used for inulin clearance in biochemistry, which
Okay,
is
sir.
the GFR. But then logistically, poking a child 5 times is not possible. Then they said, we will just use the first one and the last one. And extrapolate and make a curve out of it.
Okay.
So they said
Yes,
we do two samples. But at the end of the day, when you are using DTPA, again with all these other factors being there, it may give you an artifact, especially when you're having bilateral. So you are not going to get a split single renal GFR with that. You are still going to get a total GFR, and depend on your differential function to say this is a split GFR, and differential function, as we already know, are subjected to a lot of artifacts.
Yes, sir.
So calculating GFR on DTPA scan, calculate even the EC and MAC3 have what is known as the end plasma renal flow. So that is again something equivalent to that, saying how much of extraction occurs. But these are all numerical values which are good to have parameters on your reports, but not something which you will judge and make your decision on to operate or not.
Okay, sir. Yes, sir. Sir, then another person had a query. Among all the parameters, the numbers that we get, like T max, T half, etc., which one would be the most important parameter to decide for a surgical intervention, for example, pyeloplasty, and why?
So most of these parameters, like I said, you see, for saying T half, I didn't touch upon C half at all, because that's something which we never use nowadays. To say T half is the time taken for the peak activity to become half of that.
Yes,
Most
sir.
of the renal scans are stopped at 20 or 30 minutes.
Yes.
So if you look at the curves, you have still not reached half the activity. If you take any EC scan, for example, and look at the time activity curve, and you see the peak activity of the affected kidney, let us say it is 500 kilocounts,
Okay,
and
sir.
you take 250 and draw a straight line, it will never touch the curve, because the study has been stopped. To have
Yes.
a proper T half, you have to have a study continuing till that touches that point, which would mean
Yes.
sometimes continuing it for 2-3 hours, because you see at the end of the delayed picture, after 2 hours also, your activity is still so high.
Yes,
So
sir.
you will never get a T half. It will be infinite. So you cannot continuously prolong the T half for that. And
Yes.
any T half which they say about 20 minutes is likely to be obstruction earlier days, it still, if you say that at 20 minutes, it's suppose it is 25 or 30 minutes, going by the original definition, about 20 would have been obstruction. But if
Yes.
the kidney has come down to half the activity in 30 minutes, if you looked at the different 2 hours picture, it would have completely cleared. So that would have never
Yes.
been an obstruction.
Yes, sir.
The
Yes.
same thing holds good for even cortical transit time and all this thing. In fact, if you look at one of the papers which came out long back, there are almost 57 parameters which were listed out. And finally, at the end of the day, we boil down to only looking at the scan with experience, look at perfusion, how bad or how good it is, which tells you that kidney is significantly affected. Look at the post-void delayed picture to say that there is significant hold up and more hold up compared to the beginning of the end of the time activity curve of the 20 minutes, which says there is definite obstruction. These two are enough for you to say there is obstruction, there is compromised perfusion. Then you can use the differential function just to add on one more parameter, and many criteria used to come. We say we will operate if it is less than 40, we will operate if it is less than 30. But I don't think that is an absolute criteria when you have these sort of, like I showed you that picture where it was 40
Yes.
or
Yes, sir.
45. But that
Yes, sir.
fellow had poor perfusion, that fellow had significant hold up, and that fellow's ultrasound had showed significant cortical thinning. And because those days we used to say we will use that as a parameter, the repeat ultrasound had showed further thinning with no change in the differential function. So differential function by itself is good to have as a number, especially when it's very low, to tell the patients, we can at least compare post-operatively to see what is the improvement. But what is borderline normal or hyperfunction is something we wouldn't look at. So I would
Yes.
say 3 parameters in the order of preference: post void picture to show obstruction,
Yes,
perfusion
sir.
picture to show compromise function, and plus minus differential function. These are the things you
Okay.
should do. And when in doubt, repeat after a period of interval and use ultrasound also as a parameter. In fact, one important ultrasound thing which we never looked at in unilateral is contralateral compensatory hypertrophy,
Hypertrophy. Yes, sir.
which is not talked about much. That is a very good parameter if you have a proper ultrasound growth curve charted. In fact, there is a paper which in fact I had published during my PG days where we have looked at contralateral hypertrophy. The growth curve of the contralateral normal kidney changes the moment you do a pyeloplasty.
Yes.
So these are the parameters I would be looking at.
Okay, sir. Sir, then in a case of one side MCDK with a contralateral VUR, how would we ascertain function since it's a differential function?
In the case of
One side will be MCDK, sir, and the
Ah.
opposite side has a VUR. How to
Hmm.
ascertain the function of that VUR kidney?
See, function, if it is the moment you say MCDK, it is going to be 100% function. No? So there is no question of
Yes.
asserting any function.
So we
What
just
are
have
you
to see
going
the
to look at the
scars.
VUR? Why would you even want to do a isotope renogram? I mean, EC renogram for a child with MCDK. MCDK most of the time is an ultrasound diagnosis.
I think they mean on a DMSA, sir, how to ascertain the exact function of that kidney. But I think that number cannot be.
No, whatever isotope scan you use to fulfill the criteria of an MCDK, that kidney will have zero function.
Yes, yes,
So
sir.
the entire kidney of this will be 100. So there is
100.
no differential function in that at all.
Yes, sir. So we just have to see the scars and
Yeah, you would
the
see the scar. On
outline.
the DMSA, you look at scars. And
Yes, sir.
you wouldn't do a EC scan in that
No,
patient.
no.
When
Yes,
you're
sir.
doing, sometimes when you have a doubt, we would like to do a DMSA to make sure that it is an non-functioning kidney. Even in PUJ obstruction, sometimes you get 0% grossly hydronephrotic kidney.
Yes.
So that is something I won't go into. How will you manage and all? It's a totally different topic. So differential function in a solitary functioning kidney has no meaning. It is only
Yes. Yes.
if you have a solitary functioning kidney with PUJ obstruction or PUJ with VUJ obstruction, you are going to look at perfusion, drainage, intervene, look at improvement in perfusion, drainage. That's all.
Yes. Yes, sir. Okay, sir. Sir, then in a case of a kidney that has not been located by ultrasound, for example, incidentally detected renal agenesis, we can suspect that it can be an ectopic kidney hiding somewhere in the abdomen. So what should be the instruction that is given to find this ectopic kidney anyway? Because we need to mark the ROI in such cases. So how do we go
So
about
what the ROI is marked post scanning.
post
Okay.
scan? Okay.
ROI is marked on the computer when you sit down after you finish the scan.
Okay.
The ROI is marked at the time you want to do all this calculation. This is all bench work.
Yes, sir.
So when you are recording, generally if it's a kidney which is not picked up on an ultrasound, we wouldn't be looking at doing a diuretic renogram. We would be looking at doing a DMSA scan to pick up
DMSA.
wherever kidney tissue is there.
Yes, sir.
And when you do the DMSA scan, we would be incorporating the entire area from the upper, because sometimes there are rarely thoracic kidneys also. So you will be, and when you see all these DMSA, EC scans, the initial pictures also include the heart right up to the pelvis.
Yes.
So
Yes,
you
sir.
would record the whole activity, and in the DMSA at 2-3 hours when you take the static images, after that you will see wherever there is activity. DMSA also doesn't have alternate routes of excretion. So wherever there is activity, it will be kidney. On the other hand, MAC3, another example about MAC3 I would wanted to say was MAC3 having hepatic activity. Now there is so occasional situations where you have a right-sided hydronephrosis and you have done the MAC3 instead of the EC or a DMSA.
Yes, sir.
And the liver because that is poorly functioning or background activity is very high, the liver
The
excretes.
liver takes up. Yes,
And
sir.
when the liver excretes, when you do the delayed post-void picture, there is activity in the intestines. And there
Yes.
have been situations where the ascending colon cecum activity has been misinterpreted as the megaureter of that side. And
Okay.
confusion saying ultrasound is showing only hydronephrosis. When I did the MAC3, it is hydroureteronephrosis with VOG obstruction.
Okay. Yes, sir. Yes, sir.
So
Understood.
similarly, when you do a DMSA scan, that is the reason for this, you do DMSA, there's no other excretion. So wherever you see activity, there is kidney. And that is the reason you need an anterior recording of the DMSA when you do this for ectopic kidneys, because most of the ectopic kidneys will be picked up on the anterior view. And if you calculate
Yes.
differential function, you need the anterior view so that the posterior background activity do not interfere.
Understood, sir. Yes, sir. Sir, also in that when we're calculating the differential function, you had mentioned those two parallel lines that are drawn on the graph. So, and the position at which, I mean, the time at which we decide to calculate that differential function will change the numbers, of course. So, how do they exactly decide at what point in time they take that?
So that is the thing you can do about, because any nuclear medicine lab, the
Yes.
software comes directly from the IANEM,
Okay.
National Atomic Nuclear Medicine, this thing. And
Okay.
the protocol is MAC 3 or DTPA.
Okay.
Whatever protocol is put in the software, automatically the computer will put the line and record that time. You cannot do
Okay.
anything about it.
Okay.
So if you really want to do, like I said, you draw your lines.
Okay.
Okay.
Yes.
But having said that, that is the reason differential function, there is so much of ambiguity. Differential function cannot, unless the peak activity of both kidney occurred at the same time, will never
It
be
is
a true differential
unreliable.
function.
Yes, sir.
And
Yes.
peak activity of both kidney occurring at the same time would generally be in a non-obstructive system.
Normal system.
So
Yes.
differential function, yes, it gives us some idea and it helps us in comparison, but it's not an absolute number by itself.
Okay. So more than depending on the numbers that they give us, we have to see the graph as well as the
Yeah.
perfusion.
So for example, I showed you the first graph, this graph. Here it is so obvious, there is definite difference.
Yes.
But sometimes it, this may be just here, this may be here.
Yes,
Then
sir.
this is going up and that is coming on. Then it becomes difficult to say. But in these sort of situations, there is no ambiguity, so you can still accept to some extent
This
confidently
number.
these numbers.
Yes. Yes, sir. Understood.
And these other examples, like I said, there is one good presentation by Manchester on nuclear medicine. If I catch it, get it, I'll send it across to the group.
Yes, sir.
Which says, the background, how to say that the subtraction is correct or not. So they sort of extrapolate this and see, when there's a lot of plateauing there, they actually extrapolate it and then show where the straight thing would join this. And that tells us whether the subtraction has occurred over, under, or correctly. If it comes and meets it 0, it is correct. If it meets it here, it's over. If it meets it somewhere here, it's undercorrected. But
Yes.
the problem with these are, like I said, most of them will inject it as a bolus.
Okay.
And then when we are doing it, we do sort of dilute. So protocol difference from lab to lab. So there are a lot of differences even in that. I mean, if you can sit and go through this and create so much of artifacts, there is no end to it.
Okay. So even say, for example, like we said, like a well-tempered renogram should start from 0 and then have an upslope and then come down. Even if it's not like that, we can see the perfusion images and come to a reasonable
Absolutely.
conclusion.
So what you can do is, see, most of you would be relying on nuclear medicine labs are not so many in the every city. So most of you will be always sending it to the same person.
Yes.
It
Yes,
would be
sir.
worthwhile going and talking to that person, seeing the things, 1 or 2 scans when they're actually doing it, discussing these points and developing your own protocol so that every scan, when you do, you know what to look at.
Yes, sir.
These are information which you know to keep in mind when you get a scan done elsewhere, so you know how much of importance to give, because sometimes it's important again to look at the aortic thing. Sometimes when they inject, there may be extravasation.
Yes.
And when it's extravasation,
Yes, sir.
reabsorption occurs and then it still gives you a renogram. But it is totally flat curve. It doesn't give you a smooth.
There's no uptake. Yes, sir.
Very gross hydronephrosis, it may again interfere with interpretation. So there have been, in those situations, they actually stop the study, give it 3-4 days time for all that decay to occur and then repeat it.
Yes, sir. Yes, sir. Okay. Sir, a couple of more questions, sir. One person has asked, post pyeloplasty EC scan, how do we interpret the changes, what to expect, and how to use that scan for counseling parents?
So one thing is, when we talk to the parent before the surgery, we always need to tell them that we are relieving an obstruction.
Yes.
And that obstruction relief is going to prevent further damage to the kidneys.
Yes, sir.
There is a potential for improvement in kidneys function if the children is young, even in older children, yes. How much we will never be able to justify. The numerical value given to you before the surgery has lot of artifacts and may not reflect the true value. Post operatively, if I get a drop in function, but an improvement in drainage, I am going to accept the improvement in drainage as the correct response and not the drop in function and get worried about it.
Yes. Yes.
Then when I also need to talk to them about the ultrasound, because many times what happened, EC scan will show good drainage and the function also might have improved, but
But the
ultrasound
APD
keeps showing
will be-
persistent dilatation.
Yes. Yes, sir.
That is another thing they need to counsel them. So when they counsel, they have to talk to them about ultrasound dilatation, not resolving, differential function, improving, not improving, worsening, drainage being the main parameter on the EC which we are going to look at, and ultrasound cortical thickness and all will start improving.
Yes, sir. Okay, sir.
So that is the thing that that has to be reinforced to them repeatedly, especially when you have these sort of closer to normal function. I mean, something which is 35, something which is 17, 18, it's very unlikely that it's an artifact. But 17, something which is 35 or 38 may be an hyperfunction, and post-operatively it may still say at 37, 38, or it may actually come down to 30.
Yes, sir.
So these are the scans where you need to reinforce to the parent before the surgery what to expect.
Yes, sir. So
Because
one last.
the reports which are given totally by people who don't know anything about what you are doing.
Yes, sir.
Tomorrow, this has medical legal implications. They can go and tell that you operated and the kidney function worsened.
Yes. Yes,
So
sir.
it is very important to document, and it is good to have a rapport with the nuclear medicine guy also to put that clause. Earlier I used to have report which says maybe a hyperestimation.
Yes, sir. Many are adding it now at the
So
bottom.
that sort of is good to have, so that you are protecting yourself legally also. At the same time, you are conveying to them that this is not a very important parameter.
Yes. Yes, sir. And sir, last question, sir. Someone has asked whether you have experienced an improvement in renal perfusion post pyeloplasty when you do a follow-up scan.
Yes, because the idea is for relieving the obstruction, and perfusion is mainly because of the obstruction back pressure.
Yes, sir.
And when we do a scan, perfusion improvement and the drainage both generally improve.
Yes, because
And
the pressure is relieved.
the timing is variable. I mean, we will do sometime at 6 months, but generally, if the ultrasound is showing good resolution, the post-op renogram can be done at 1 year after pyeloplasty.
1 year. Okay, sir.
Some of us do at 6 months also, but generally, if the ultrasound follow-up is showing good resolution, 1 year is good enough. That would have given maximum time for everything to settle down and everything. On the other hand, if there's some ambiguity in the ultrasound and things like that, you have had some leak in the perioperative period and you are scared about adhesions, strictures formation and recurrent things, then you can go ahead and do it early.
Okay, sir. Yes, sir. Understood. I think that's all the questions we have, sir, for today. Thank you so much, sir. Your lecture was so great. I didn't even realize 1.5 hours has gone by also. Thank you so much, sir. This is a very difficult topic for most of us. I think at least we've got some clarity on this issue now.
Yeah, so I think my only message would be that always report it yourself before looking at the report.
Yes, sir. Yes, sir.
That is the only way you can learn.
Yes. Yes, sir. And I think this particular lecture will actually encourage more people to join our lecture next time, since it was so useful for us. Thank you so much, sir, for your valuable time.
Thank you. Thank you.
And thank you to all participants for joining today. We'll announce the details of the next lecture within the next 1 week. Thank you all.
So I'll sign out. Thank you
Yes,
very
sir.
much.
Yes, sir. Thank you, sir. Good night, sir.